we continue where we left last week. So we were talking about filling, and of course, related to that, the assessment of diastolic function or diastolic dysfunction. Just to quickly come back to that, just quickly repeat, because in the end, it comes all down to some of these basic principles. So when we look at the filling of the ventricle, so we have to see how the blood will go from the atrium to the ventricle. And that, of course, depends on the pressure difference between the two. So you can only have flow when you have a pressure gradient. So that means that we have to look at how the pressure in the ventricle goes down and then goes lower than the atrial pressure. So because at the moment that the left ventricular pressure becomes lower than the left atrial pressure, then the valve will open, the mitral valve, if we look at the normal left side, and the flow will start. And the flow will continue until the pressure equalizes. And then later on, it might be, and we'll come back to that in a minute, when you have atrial contraction, what can happen is that the atrial pressure can rise again and thus again create a gradient in order to do the filling. So obviously for the left ventricle, for the pressure to go lower than the left atrium, that depends on how fast this pressure will drop. So this kind of the pressure gradient, so the deceleration of the pressure or the drop of the pressure, that is quite important. And then that determines also the time at which we will have a crossing of the pressures of the left ventricle and the left atrium. And so it's clear that this kind of the drop of the pressure in the left ventricle depend on the intrinsic relaxation. So as we said before, it's like when we look at the contraction, we see that we have actin myosin, which is interacting. And as long as the cross bridges between these are formed, the left ventricle is functional stiff. So what you need to have is that these cross bridges are broken down in order to have optimal elasticity, and that the kind of elastic energy that was stored during the contraction can be released, and we have a fast decrease of the pressure. So either if this contraction is for whatever reason longer, or the relaxation, the cross bridge breakdown is slower, what we will see is that the pressure in the left ventricle will decay slower. And then of course, it's much later that the filling starts. And of course, the later the filling starts, obviously the less volume you will have during this early filling phase. And the other thing is, of course, the intrinsic tissue properties. If the tissue is stiffer, it's unlikely that you can store a lot of elastic energy during the contraction. And what you will see also is that then this pressure decay will be delayed and will be slower than that it normally will be. So looking at this pressure decay, so this is one of the things which is important. And the other thing which is important, obviously, is what we can say like the end diastolic pressure or the left atrial pressure, where of course the higher the left atrial pressure will be, the earlier you can have a crossing of the left ventricular and the left atrial pressure. And so when we look at the time of valve opening, as we said last week, what we see is that the time of valve opening will delay the slower the relaxation, but will shorten again the higher the left atrial pressures. But as you can see, it always comes down to trying to think about what is the pressure difference between the atrium and the ventricle, and then how is the ventricular pressure going down, or how high is the atrial pressure to start with. And so when we look at the early filling, we have these phases and these signals that we look at. So as we said before, obviously looking at the pressures, that tells us directly the driving forces for the flows, but of course it's extremely difficult to do that minimally invasively. So you would always need to put in a catheter. So that's why what we try to do is we try to look at the things that we can measure easily with imaging. And as we said before, so looking at the velocity through the mitral valve, so that's like the E-wave filling, is interesting. Looking at the pulmonary vein flows is interesting. And also, as I said last week, looking at the annular motion would also provide us some information. Now, where the early filling is quite important, and as I said before, also it's like a normal heart, and especially a young heart, will actually almost fully fill with the early filling, because that's the most energy efficient in some ways. Because what happens is that during your contraction, so your ventricular contraction is the one that can happen with the most force and most energy. So if you use that to store elastical energy, which is then later on released in the early filling, that's the easiest way or the most efficient way to do the filling. And also, if you have this fast relaxation, you have that the pressure goes down a lot in the left ventricle, and a lot of fluid can come in this early filling period from the atrium. Plus also, what we have is that, of course, during the atrial filling, what happens is that also, of course, blood is coming already from the lungs. So continuously, blood will go from the lungs directly to the left ventricle in what we can call like a conduit function of the atrium. So what happens is the mitral valve, when the mitral valve opens, the atrium already empties a little bit, but it's mostly blood coming from the lungs on the right side, which comes in there. And so it's very efficiently to do that filling. Now, what we will see is when we start looking at abnormalities, and we mentioned that also in some of the other classes, what you will see is that the myocardial tissue, when you start to get older, is going to change. Your vessels are becoming more stiff. So what you will have is that, and for example, your endocardial tissue is becoming slightly more kind of fibrosed. So you have a little bit of more collagen there. You likely have higher pressures because of the fact that your vasculature gets stiffer. And also, of course, because of this, if you have higher pressures, as we said before, you will actually do slightly longer contraction in order to do the ejection. And additionally also, because the part of the myocardium which is affected earliest is the endocardium. And keep in mind, the endocardium, as we said before, has longitudinal fibers. So the endocardium will also make or give an important contribution to the ring motion. And so because of all of these things, all of these effects make that when we age or when we start to get towards some cardiac abnormality, even the slightest abnormalities, especially the ones involving the endocardium, what we will see is that this early filling will become less and less efficient. And mainly that we have the relaxation will be slower, which can be because of, as we said before, both the tissue components, that the tissue is a little bit less elastic, the fact that we still have some cross bridges which are connected in the early filling, and that we also have less longitudinal displacement of the ring, which, as we said last week, contributes more to the filling than the circumferential displacement. So because of all of these factors, what we will see is that the component or the amount of volume that can come in the early filling will decrease. So we will start to get that the valve will open later, and also that the pressure gradient is less. So that means that both the IVRT lengthens, so the onset of the early filling, and the velocity of the early filling, they will go down, which means the total amount of volume is less. That means that in order to be able to still fill enough, in order to be able to fully fill, to generate a full stroke volume during the next ejection, what needs to happen is that the atrium has to push in more blood. So then we have atrial contraction, and the atrial contraction will actually fill the ventricle with what it couldn't fill in the early filling period. So that, of course, implies that, as we said before, in young people or very fit people, since the early filling is so efficient, that means that the atrial contraction is not contributing much. But the older you get and the more diseased you get, the more important this atrial filling will be. And so the atrium has to contract more in order to push blood. So looking at this atrial contraction, and that's what we would call the late filling. So the late filling is, of course, started by the electrical activation of the atria, which actually, as we mentioned before, also that's the physiological beginning of the whole cardiac cycle. So from the sinus node that activates, will then activate the atria. The atria will contract. And so what's happening is that due to atrial contraction, we will have an increase in the atrial pressure. That will, of course, create a gradient, again, between the atrium and the ventricle, which means that flow will start. And so that leads to the A wave in the mitral valve. And so the onset of the A wave is related to the onset of the mechanical contraction of the atrium. Keep in mind that there might be an electromechanical delay of especially the contraction of the left atrium, because the sinus node is in the right atrium. and the electricity has to go to the left, but we'll come back to that at some other point when we talk about heart failure also. But so when the deformation of the atrium is starting, or the contraction of the atrium is starting, the pressure increases, and that's the onset of the A wave of the mitral flow. And then, of course, the velocity of the A wave will depend on the pressure gradient between the atrium and the ventricle. So the higher the pressure being generated in the atrium, of course, the higher the E wave will be. Now, one thing which is very important, and I mentioned that last time also, but you always have to keep that in mind when we look at the atrium. So at the moment that the atrium contracts, of course, the pressure in the atrium increases, which means that there can be flow towards the left ventricle. But when we look at the pulmonary veins, what we see is that, of course, there are no valves in the pulmonary veins. So that means that also when the pressure in the left atrium increases, that means that likely the pressure will become higher than the pressure over the lungs, or likely than when we look at the pressure in the right ventricle at some point, or at least in the pulmonary artery. So that means that we start to get a reversal flow in the pulmonary vein. And so when we look at the pulmonary vein, so because of the fact that the pressure in the atrium increases, we have backflow in the pulmonary vein, and we see that in the pulmonary vein flow, we see this kind of pulmonary vein reversal flow during atrial contraction. Now, another thing which is also important is that you have to look at the timing of the flows. So what happens is that the flow starts, or as soon as you have a higher pressure in the left atrium compared to the left ventricle, you will have flow. In principle, the flow will stop when there's no pressure gradient anymore between the two. So then the A wave will stop. But keep in mind that this will be when there's equalization of the left atrium and left ventricular pressures. But also when you have equalization of the left atrium and left ventricular pressures, what happens is that, of course, the mitral valve starts to come back. And especially in a normal cardiac cycle, what happens is that after the atrial contracts, what happens is that after a certain delay through the AV node, we start to have ventricular activation. So that means that what you normally would hope is that you have atrial contraction, and at the end of the atrial contraction, now the ventricle starts to contract, because then, of course, the mitral valve is closed. We will talk a little bit more about mitral valve dynamics at some point, but the way that the mitral valve actually closes physically is actually two components. What happens is that the atrium contracts, then the atrium starts to relax, and by atrial relaxation, the pressure in the atrium will start to decrease a little bit, so that actually there's again a reversal here. So you see here, when the atrium starts to relax, what happens is that at some point the atrial pressure might be lower than the ventricular pressure, which starts to kind of suck the mitral valve leaflets towards the atrium. And ideally, in an ideal cardiac cycle, so at the moment that the valves are moving towards the atrium, then the ventricular contraction is starting, builds up the pressure in the ventricle, and fully closes the mitral valve. So this is the most efficient way to close the mitral valve, because of course, if the ventricular contraction would happen when the mitral valve leaflets are still kind of fully loose, what will happen is that you start to get some flow from the ventricle to the atrium. So you would have some regurgitant flow. That would be very inefficient. So normal atrial relaxation would prepare the mitral valve leaflets for closure, and the full closure, the tight closure, would be with the ventricular contraction. Obviously, when the ventricular contraction, for whatever reason, would be a little bit earlier than the end of the contraction of the atrium, what happens is that, of course, because the ventricular pressure rises much faster and much higher compared to the atrial pressure, what happens is that, of course, as soon as the left ventricle or the ventricle contracts, it will push the mitral valve back and will close the mitral valve. So what you will see now is that in cases where the atrium has to contribute really a lot to the filling, or where you have, for example, a delay in the contraction of the atrium, what now can happen is that the atrium is contracting, but before the atrium has fully contracted, the ventricle already starts to contract, will close the mitral valve, but the atrium is actually still contracting. So the atrium keeps on contracting, so keeps on generating some pressure. And that means that if the mitral valve is closed, of course, the flow cannot go through the mitral valve, but actually the flow, or even more flow, will go back to the pulmonary veins. So that means that the timing of the A wave through the mitral valve is related, of course, to the atrial contraction, but stops at the closure of the mitral valve. And the closure of the mitral valve, as I said, is because of the difference between the left ventricular pressure and the atrial pressure. You would hope that you first have a little bit of negative atrial pressure and then onset of ventricular contraction. That will be the most efficient. Then you don't lose anything. Then there's never a high pressure of the atrium against a closed mitral valve. But in several circumstances, what can happen is that actually the atrial pressure still remains relatively high. Of course, in this case, lower than the ventricular pressure, but remains high for a longer time. And that actually means that your pulmonary vein reversal can actually be longer than your A wave duration. So now that means that looking at the timing of these events will provide you some more information of what's going on. So what we now want to know, so what we are interested in is, when is the onset of the A wave? So when is the flow starting? Because that tells us something on when the atrial pressure can be higher than the ventricular pressure. Especially comparing left and right would be interesting. So normally you would hope that atrial activation and the onset and so the pressure buildup would be similar in left and right atrium. So that means that left and right A wave would start at the same time. So mitral and tricuspid A wave would start at the same time. If there is a delay, that already tells you that somehow there's a problem. The next thing is looking at the amplitude of this wave, because that amplitude will tell you how high the pressure of the atrium will be. So how much is the atrium contracting? And that will be more and more, the more important the atrium, or the higher the atrial pressure will become, or the more need there is for atrial filling. So looking at the amplitude of the A wave is interesting. Looking when the A wave in the mitral is stopping, then with regard to the next cycle, that would be interesting, or with regard to the ECG. So that is quite important. And then looking on the fact, first of all, then looking how much regurgitant flow there is in the pulmonary veins, because if we don't need to do a lot of atrial contraction, as we said before, in very young children and very fit athletes, there is almost no atrial filling. That means that there will be almost no pulmonary reversal flow. If there is a lot of pulmonary reversal flow, we know that the pressure in the atrium has to be very high and much higher than the pulmonary pressure. And also, if we see a prolonged kind of reversal in the pulmonary vein with regard to the forward flow in the mitral valve, we know that the atrium is actually still contracting while it actually should have relaxed. So that means that by combining this information, and especially what is very, very interesting is looking at this reversal flow and this timing of reversal flow, we can know something about the dynamics of the atrial contraction and about, of course, the atrial pressures. So keep in mind, all flows is differences in pressure. So we cannot measure absolute pressures, but we know that the higher the absolute pressure in the left atrium, the more reversal flow we will have. And likely, the longer the atrium has to contract or is contracting against this high pressure, because the same dynamics as what's happening in the ventricle against a high pressure will be for the atrium against the high pressure, meaning that the contraction will be slower and will be longer. So you will have prolonged contraction of the atrium. And then, of course, we see this prolonged kind of duration of the pulmonary vein reversal A flow as compared to the mitral reversal A flow. So time aligning, or at least looking at the time differences between all these flows, this gives us this kind of information. At the same time, so when we look at these things, so obviously what we said before, so the contraction is what we want to look at for the late filling. With regard to the timing, is there an electromechanical delay? Yes or no? With regard to left and right atrium, is there an interatrial delay? So that's what we want to look for. The mitral valve flow will tell us something, but of course also the annular motion, because what happens is that, of course, as we said before, when you look at the ventricle, ventricular contraction, normal ventricular contraction would drag the mitral valve down towards the apex. So we have downward motion of the mitral ring. Then with the early filling, of course, we have the upward motion, which is like the elastic recoil. But of course, then if the atrium contracts, what happens is that the atrium will drag along or drag upwards the annular motion a little bit more. Now, there's still a little bit of, let's say this is still partially a gap in our knowledge, but when you look at images, you can see that actually the upward motion of the ring is predominantly the early relaxation. And what you see with atrial contraction is, of course, while the atrium will drag up the valve a little bit more, what you also see is, of course, you have a lot of circumferential contraction of the atrium. So it looks like with early relaxation, the atrium will shorten passively, obviously, because there's no contraction. And then with atrial contraction, you mainly have that the walls move towards each other and still with a little bit of upward motion. So you would still see a little bit of upward motion there. So looking at this annular motion, the amount of annular motion, that will tell us something, because what we said before is like, if you have a relaxation problem of the ventricle, so there's almost no relaxation, so there's almost no upward motion during the early filling, then of course you might have a lot of upward motion during atrial contraction. And then looking at the pulmonary veins, as we said before, that tells us something about both the duration of the contraction between the atrium and the ventricle and the dynamics between these, and of course the pressures in the atrium itself, which would cause the reversal flow. So if we then look at what are the contributing factors and how can we look at it, so obviously the contraction, so the contractile force development and the deformation of the atrium are important, because that is of course doing the contraction. So we need to have normal tissue with normal contractility in order to have the atrial contribution, of course. So that means that whenever there's a problem with either the contractility or with the atrial tissue, so if we have lost contractile material for whatever reason, so that will become a problem, or if we have a lot of scar, then of course also we will have that the elasticity of the tissue will become less. So even if you have normal contractility of the atrial myocytes, but you have a lot of scar, of course, the amount of deformation will be less. When we look at the mitral flow, so the mitral, the A wave, the maximal A wave, so that will be the A value that is normally reported in most of the echo reports. So you just look at the maximum. That, of course, is a direct reflection of the pressure difference between the atrium and the ventricle. So that pressure difference can be higher if we have increased contractility of the atrium. So if the atrium is contracting more vigorously or more, of course, this A wave will increase. So that means that when we have an increased atrial contribution to compensate for the lack of the early ventricular contribution, we will see that we have an increased pressure in the left atrium, and so we have an increase in the A wave. And of course, it will also be dependent on the stroke volume. So, and these are related, because we need to increase the stroke volume, and in order to increase the stroke volume, we have to increase the strain. We can do that also by increase the strain rate with the contractility, or also by doing a longer contraction sometimes. So we have to look both, not only at the maximum, but of course also at the integral of the mitral wave, because that tells us about something about the stroke volume. Now, keep in mind that, of course, this velocity has to do also with the size of the ventricle. So, as we said before, if you have a bigger kind of cavity with less deformation, we can still continue to do a lot of stroke volume, or a normal stroke volume. Or if we have an increased size of the atrium in this case, and we have still a lot of deformation of the atrium, of course, we generate much more stroke volume during that time. And so, of course, also this A will also be related to the ring. If we have ring dilatation, so if the size of the ring becomes bigger with the same stroke volume, we would have a decrease of the A, or if we have a maintained A with a larger ring, we of course have a larger stroke volume. So that means that also looking at the size and measuring the stroke volume by either looking at the integral of this, of course, multiplied by the area of the valve, or by looking at the kind of a segmentation of the atrium, that is something which is also relevant in order to look at what is in the end the contribution of the A fill. Then the duration of this A wave is really important. And again, this duration depends on the pressure difference. So the A wave will stop at the moment that we have equalization of the pressure in the left atrium and the left ventricle. So this can be longer if we have a delayed contraction. So if we would have a kind of PR interval, which is very, very long, so if the left ventricle starts to contract late with regard to the atrium, of course, we might have a longer duration there, because it's this upward motion of the, or this going up of the left ventricular pressure, which will likely fully close the mitral valve. The later this will be, the longer this duration will be. But of course, what also happens is that if we have a faster rise in the ventricular pressure due to atrial contraction, so you see that here, of course, when the atrium contracts, it will push flow, or it will push volume into the ventricle. But of course, since the ventricle is an elastic body, the ventricle has to expand in order to kind of contain this volume. But because it's elastic, of course, the pressure will increase when you push volume in there. So that's what you see here. So your atrium contracts, volume gets in, the ventricle extends a little bit to take this volume, but of course you need energy for this, and that means that also the pressure will increase there a little bit. Now, if the ventricle is very stiff, so if for whatever reason, it can be fiber disarray, or it can be fibrosis, it can be deposition, this ventricle is very stiff, then of course, if the atrium contracts, it wants to put blood in there. So in order to extend the ventricle, which is much stiffer, of course, the pressure of the atrium has to be much higher. And so you also much more likely have that the pressure equalization with atrial contraction is faster. If the ventricle doesn't absorb this, and the pressure will increase quickly, so that means that this pressure in the ventricle will rise much faster because of this atrial contraction, then of course we will see a faster kind of equalization of the pressure, and we will see a shortening of the A wave. So if you have a very, very short A wave with a very, very high velocity, you know that you have a very high atrial pressure, likely a very high contractile contribution of the atrium, but a very stiff ventricle that cannot kind of take this volume. And we know that we have extremely high left ventricular and diastolic pressures. So that means the filling pressures, as we say, which is the left ventricular and diastolic pressure, which is of course related to the atrial pressure during contraction, that will be very high. So looking at the duration here tells us also several things. It tells us something, especially again, comparing with the duration on the ECG, you always have to look at what is the driving kind of events, or what are the driving forces, and how are these reflected in everything. But it's always an interplay of different things. It's the pressure in the atrium, the timing of the atrium, the contractile force of the atrium, the stiffness of the ventricle, which is also partially related to the size of the ventricle, because a very small ventricle has to expand a lot in order to take the stroke volume of the atrium. A very large ventricle doesn't need to expand a lot in order to take more volume. So we know that, but a larger ventricle might be stiffer for different reasons. What we mostly see is that the small ventricles in cardiomyopathies, for example, a hypertrophic cardiomyopathy, has mostly a very small cavity, a very thick wall, but because of the fact that the wall is thick and has a lot of fiber disarray, very often a lot of collagen and fibrosis, makes it very, very stiff, which means that the pressure increase will be very high with the atrial contraction. And that means that we likely have a very, very short A wave. Now, of course, also, if you have that the ventricle is so stiff, so the atrium starts to contract, the pressure equalizes quickly, but the atrium can still be contracting. So that means that the pressure, or at least can still have high pressure, although it cannot deform a lot because no volume can enter the ventricle, the pressure can still be high due to continuous contraction of the atrial tissue. But that means that there, of course, we have continuous reversal flow to the pulmonary veins. So here again, looking at the dynamics between the duration of the forward flow and the backward flow in relation to, of course, the closure of the mitral valve and the timing of the ventricular onset of contraction will tell us something about both the stiffness of the ventricle and then of when the ventricle is contracting. Yeah? And so that's what I'm saying here. So looking at the pulmonary veins, so that's related to high pressure. So high atrial pressure is the driving force to generate a kind of inverse pressure gradient between the left atrium and the pulmonary artery, and thus brings blood back into the lungs. And that timing can be very, very different from VA. Unfortunately, in clinical practice, a lot of people, and also because it's not anymore in the guidelines or not proper anymore in the guidelines, not too many people are looking at the pulmonary vein reversal flow. It's also perceived to be more difficult to acquire, and you mostly need a little bit, or you potentially, especially in more difficult patients, you need a little bit more time in order to find a good signal, and so it's very often neglected. But actually, it's the only way, by combining these, it's really the only way to properly look at the pressures and which is actually the cause of, for example, whether there are increased pressures and what is the cause of these. Now, one thing which is also, when you start thinking about it, what we said before is if you have pressure overload, what you get is you get a trigger for the myocytes to make more contractile material and become hypertrophic. So that's the same. Atrial myocytes are not very different from ventricular myocytes in this respect. It's like if they need to contract more and they contract with higher pressures, they will become hypertrophic. So you get hypertrophy of the left atrial cells and you have more contractile force at your disposal indeed. The difference is now is that when you have ventricular high pressure, what happens is you get hypertrophy, and actually this hypertrophy also makes that the wall thickens, but that the endocardium thickens towards the inside in order to also decrease the size of the cavity, because we know when we look at Laplace law, means that both a thicker wall and a smaller cavity, so a smaller radius of curvature, will reduce the wall stress. However, the atrium, when it becomes thicker, ideally it would also become smaller, but keep in mind that we have this lack of valves towards the pulmonary veins, and actually what we get is, because of the high pressure and because of the retrograde flow, we actually are generating a volume overload of the atrium. So even though the initial driving force is the increase in pressure in the left atrium that is needed in order to generate more volume during atrial contraction towards the left ventricle, as a consequence of the reversal flow, which increases there, the pressure overload will be immediately associated with volume overload. And it's the volume overload that actually will make, of course, that the atrium has to grow. So because we know dilatation is the way to cope with volume overload, because with a bigger kind of cavity with the same amount of deformation, we can generate a bigger stroke volume. This bigger stroke volume is needed to do the forward flow towards the ventricle, but also the reversal flow towards the pulmonary veins. So that means that even if it's pressure overload of the left atrium, with increased left atrial pressures, we actually get an increase in size. So we get a dilatation of the atrium because of the volume overload that is intrinsically associated due to the lack of valves in the pulmonary veins. So that means that actually measuring atrial size can also tell us something about atrial pressure, because atrial size in this case is related to the volume overload. The higher the atrial pressure, the more reversal flow, the more volume overload, the bigger the atrium will become. So that means that actually looking at left atrial size will also be an indirect measure of left atrial pressures. And actually, and you see this partially in the guidelines, but I think people are realizing this more and more, it's like, if you do not have any dilated left atrium, it's extremely unlikely that you have significant or long-standing increased pressure in the atrium, because that will always cause reversal flow. Only maybe in the case that you have like also pulmonary artery hypertension, so increased pulmonary artery pressures, that might be the only way that you might not have a lot of reversal flow, but these things are quite rare. So that means that looking at atrial pressure, also taking into account the atrial size, is as important as looking at the dynamics of the A wave, and as important as looking at the dynamics of the pulmonary veins. Now, what is quite interesting also, especially when we look at children, for example, what you will see is that in children, what you will see is that a lot of these diastolic parameters, especially with regards to the early filling, are not very useful in clinical practice. And the main thing is that the elasticity or the restoring forces of the ventricle are retained in a lot of children. So even if you have kind of abnormal filling, you will never see this kind of very, very stiff ventricles, or very rarely see these very stiff ventricles. But what you do see is actually this reverse. So just looking at the values of ENA will not be helpful in children, but looking at the duration of the reversal flow is, or seems to be, very helpful there. So it's really important to look at these things. Now, of course, after the filling, so after the early filling, after the late filling, we of course have a new ejection. And as we said before, the ejection is important because the ejection will actually be used in order to store the energy for the next filling. So looking at the ejection, when you look at filling, when you look at diastolic filling, it's still crucial to also look at systolic function because they are always intrinsically related. And as we said before, we're not going to go in very much detail here now, but the contraction of the ventricle is important because the contraction of the ventricle will drag the valve down. So we'll do the shortening, we'll store the energy that we need in order to have the early filling. So myocyte function is of course important, contractile function is very important. The elastic properties, the intrinsic elastic properties are important because you can only store elastic energy if you have elasticity, and also you cannot deform a lot, even with a lot of contractility, if you are very stiff already. So that is quite important. And also the loading, so the after loading, so the aortic pressure, or the fact that you would have, for example, an aortic stenosis is important because that will determine predominantly how long the ventricular contraction will take place. And as we said before, if you have prolonged ventricular contraction or prolonged actin-myosin interaction, prolonged cross-bridge formation in order to overcome the higher pressure, what happens is, of course, that your early filling will be less efficient because you didn't have time to break them down or to become elastic. So, of course, the timing of the valve opening and closure is important there. And as we said before, this downward motion of the ring is really important because what happens is that, as we said before, this dynamics of the ring will help us in order to get very efficient volume ejection with a certain amount of strain. And also what we said before is like, if you have the annular motion going down, what actually happens is you stretch the atrium. And of course, that means that you kind of increase the size of the atrium. And then of course, you get filling from the lungs already. So you have pulmonary vein flow. So you have the systolic wave of the pulmonary vein flow that of course already fills the atrium with blood that then of course can go in the early relaxation, can go to the ventricle. So this reservoir function and this downward motion during the contraction is very important for the next filling to be as efficient as possible. So all of these will contribute to the filling of the next period, so to the overall filling, of course, of the ventricle. And so, as we said before, these depend on the pressure in the aorta, whether you have pressure overload, yes or no. On the ventricular contraction is important. Now, also the time you have for the contraction, so the amount of deformation that you will have will also depend, of course, on the time you have for contraction. And that will, of course, depend also on the isotopic contraction time, because if that lengthens, of course, you have less time to do systolic contraction, which means that you have less time or less amount of energy stored or deformation that can then lead to early filling in the next phase. And this, of course, depends on the pressure difference between the ventricle and the aorta. And so here again, higher pressure, so pressure overload becomes important, or problems with contractility in the left ventricle will, of course, also change that. The total duration, as I said before, depends on the interaction. So the duration of the systole depends on how long the pressures of the ventricle can be higher than the aorta and when is the aortic valve closes. So again, afterload and contractility play a big role. And then the pulmonary vein flows, again, depend on the atrial pressure. So of course, even if you have a lot of deformation of the atrium during ventricular contraction, but if the intrinsic atrial pressure is relatively high, then of course the pressure gradient between the lungs and the atrium becomes lower, and of course you get less volume getting in there. So again, atrial pressure, increased atrial pressure will actually decrease the S wave. So you will see that you have a decreased S wave because of increased atrial pressure or because of abnormal annular motion, which is kind of expanding the atrium. So that means that even looking at the pulmonary vein S flow will tell us something about the next filling, because it tells us something indirectly about the left atrium and about, of course, the contribution from the ring motion, which is important, as we said before, for the early filling, because it gives us a way to actually get blood from the atrium to the ventricular side without having to do a lot of acceleration of the blood. So it's much more efficient, of course. So now when we look at ways to assess this, so now you can see already that you have different parameters that are going in different ways depending on the diseases. And so I'm not going to go in detail here. I'm just mentioning this, and the rest we can discuss later on. But you see already that we have different dynamics. So if we have a more severe disease, what happens is that the systolic contraction will likely go down. So looking at the S wave of the mitral ring, we will see that we see something. Definitely the early relaxation will go down because we have less systolic contraction. So that means that this ring motion will be a lot slower in the early relaxation, but likely we have also prolonged contraction or contractility problems. So that means that this will decrease. While when we look at the velocity, of course, of the E wave, as we also mentioned before, but next time we will go in a little bit more detail, what happens is that in a young, fit person, the E wave filling is the most important. So you will have a lot of velocity or large velocity in the beginning. If we then have problems with the relaxation, this will go slower and slower and slower, and the E wave contribution will become less and less and less. But if we then get worsening of diseases, what means that the atrial contribution needs to be more and more important. That means that we get more and more increase in atrial pressure, which of course will increase the gradient again between the atrial and the ventricle. So even if the ventricle doesn't drop pressure fast enough, if the atrial pressure is high, of course, our E wave will again increase. So we see this kind of biphasic or non-linear behavior. And so what you will see is that in clinical practice, by trying to make combination of these, ideally also with a combination with the pulmonary vein flow, with a combination with the timings, with a combination with, for example, PR intervals and things like that, we can actually try to figure out algorithms in order to try to, in the end, assess the severity of the disease. But that we will continue next time. Any questions? No questions? Overflow of information? So the most important thing I think here, and especially also for those that are working on the machine learning or on the platform, is what you clearly see is that we need to integrate all this information. So that's, for example, why we have all these Dopplers, and why at some point also the time alignment of all these Dopplers and comparing what is happening when and finding ways to do that, that is actually the most important. And it's up to us also to provide more and more tools together with explaining why we see these changes, of course, in order to assess this in a better way. Okay. If there's no more questions, then thank you very much for listening, and see you again next week.